You graduated from medical school. You're a doctor now. Your dreams have come true. Or did they? Now you have people second guessing you. You've discovered that sexism and racism are rampant in healthcare. What do you do? Well, this podcast is for you. Well, it is a pleasure, an absolute pleasure to have Dr. Stella Sappho with me today. Greetings to you, Doctor.
Greetings to you. Thank you for having me.
It's my pleasure.
I am Ghanaian American. My parents are from Ghana and I was born in Nigeria. And my mom is a pediatrician. So when I was growing up, I knew that I wanted to be in medicine. And I went to Harvard for undergrad, med school, and public health school. And I thought that I was going to be an academic medical clinician, teaching and become a professor. And then life happened, and I think the kind of things that kind of came up for me were I saw the way that medicine ultimately kind of broke patients and clinicians down, just the challenges of being in our healthcare system. And it made me think, doesn't feel like this is sustainable long term in terms of doing clinical medicine and teaching, as a long-term career. And I experienced a pretty tough work environment in my first kind of big job when I finished my residency. And that also kind of changed my perspective of the way that we as Black people, as Black women, survive in the healthcare system and the corporate medical system. And so, I went from kind of thinking that I was going to be a classic, academician to someone who now is a clinician entrepreneur. And, I love that for me in a lot of ways because my journey is not traditional, but it was the right one for me.
Okay, a couple questions about that. You had the experience of having a mother that was a doctor. Didn't she tell you about the reality of what it is to practice, or did she not practice in this country?
That is a wonderful question. My mom actually did two residencies. Residency is the what we do to be able to train to be full doctors on our own. So she did a residency back in Nigeria, and then she did it again when she came to the US. So she must have loved medicine because she's trained in it many times. And she is an old school physician. She was, she's retired now, but she was a full-time clinician. She would see patients Monday to Saturday, 9 to 6 in her private practice.
Private practice.
So, yes. So she was of the old model where you had your practice, you had your patients, you were able to exert some autonomy on your life and do medicine the way you wanted to do medicine. If she wanted to see a patient for an hour, she could. She wanted to see a patient for 10 minutes, she could. And so that independence and autonomy meant that she loved her clinical career. What's interesting is, as the years went on, as the decades went on, and she got closer to the end of her career, she started saying, medicine is not what it used to be. The insurance companies don't reimburse the way they need to. All these big hospital systems are trying to come in and take our patients, take the doctors. And so she started to feel it. And so I bet you if my mom trained in medicine now, she would have advised me a little bit differently. But even with everything, like I think she's very proud that I chose the healing profession to go into.
So what you saw was independence, love of practice, the ability to do it your way.
Exactly. And my first job was as a receptionist in my mom's office. When I was 13, 14 years old, I would go and sit there and answer the calls. And I saw how much her patients loved her. I saw how much she helped people. And I thought, this is the profession for me. I loved it. I loved it, loved it, loved it. And I still love it. My eyes were opened in a lot of ways.
Okay. So you mentioned that that was not your experience. Your mother's experience of independence and being able to have a relationship with her patients wasn't what you experienced. What did you experience?
So what I first saw, I think had a big impact on me. So I trained as an internist, as a doctor who would take care of adults, and I wanted to go into primary care because I love continuity of care. I love being able to
Mhm.
follow patients throughout the span of their life. And I saw my mentors in residency. I saw them really burned out. And these are people who had dedicated their lives to internal primary care who were teachers and educators. And I said to myself, man, and we were in a social medicine program, meaning that we really thought about the social determinants of health that
Mhm.
impacted patients' care. So these were some of the most committed kind of, salt of the earth clinicians you could get, and they were burned out, and they were starting to feel, I would say, in some ways disenfranchised by their experience in medicine. And so witnessing that brought up questions. Is that going to be me in 20 years? Is that going to be me in 30 years? So I started kind of questioning what the future of medicine held for me.
What was the difference between them, long hours, lots of patients, and your mother, long hours, lots of patients? What made one desirable and another one something that you could not see yourself doing?
That's a fantastic question. I think the difference, and it might have also been just a difference in the age group that we were taking care of. My mom's practice was one where she would watch these kids grow and more or less be healthy. And if someone wasn't doing well, she'd be able to get them services and help. In adult medicine in the Bronx, in the way that I trained, you would watch the same patients come in and come in and come in, until some of them just stopped coming in or some of them passed away. And so there's just a sense of here I am doing all this work for these patients that I care about, and we can't address the upstream causes, the things that are leading to their poor health in the ways that we should. And I think there's a degree of moral injury that happens over time. And I will say, unlike my mom, who, if she saw a problem, she can kind of troubleshoot it and implement a solution. For many of these clinicians that I worked with who were working in a very big hospital system, the steps to implement a solution were very onerous, right? So you're working these long hours, you're seeing your patients need things. And then when you want to help, it's like you got to really take a deep breath and figure out how you can find the energy to go through the bureaucracy to be able to help. So it was kind of death by a thousand paper cuts, if you will.
Mm.
Lots and lots of challenges from lots of different places. And I think it just wears down the best of us over time.
Interesting. Sad to hear, but very interesting. Just for those that may be listening, when you say social determinants of health,
Yeah.
what are you talking about?
Fantastic question. So, social determinants of health are all of the non-medical realities that impact an individual's health outcomes. So, for example, the way that you're educated, the neighborhood you live in, the foods you have access to, whether or not you are part of the, criminal justice system and you've been jailed, all those things are going to have an impact on your health. And so we really, as clinicians, we used to think, if a patient comes in and they have pneumonia, I treat them the pneumonia and we're finished. The reality of it is that if a patient comes in and they have pneumonia, we need to ask the question, where are they living? Oh, are they, without a shelter? Are they living on the streets? Okay, let's think about why they're getting sick and what's going on that we can actually work on those social determinants to help to protect their health. And I would say that's kind of the first step, right? There's a step even above that, which asks us to think about the policies that impact those social determinants. So, why is it that some places have food deserts? You can't get any healthy foods. And so those populations tend to get diabetes. Well, there may be policies that determine, licensing or access to real estate, and the types of businesses that can be set up in those neighborhoods. And so we really want to think about, and if you remember like one word of it, social determinants and kind of structural determinants, we really want to think about the root causes of health problems and really think about how to fix those root causes.
That's interesting. My question is that the role of the practicing physician?
Fantastic question. Fantastic question. I want to just take a minute with it.
Sure.
So, what it sounds like I'm saying is that in addition to seeing, 20 patients a day or doing multiple surgeries a day, now doctors need to go and fix the upstream causes. And no, that's not at all what I'm saying. What I'm saying is that we have to be cognizant of the role that we play in
Hmm.
connecting those upstream causes to poor health. Because the people who make those determinations, the elected officials, the business folks, etc., they're often very divorced from seeing the end result of poor policies. And I'll give you this very stark example. If you are an emergency room doctor and you've seen children's bodies blown to pieces by assault weapons, that changes you for the rest of your life. The way you can testify to that is something that is powerful, that our elected officials who determine the gun policies need to hear about. And so it isn't so much that we as clinicians need to go out and, change those policies like you're an elected official and you're doing it. It's that we have to know that we have a role in bearing witness and speaking truth to power about what we're seeing and making those connections, saying this patient doesn't just have pneumonia because they have pneumonia and that's it. They have pneumonia because they're unhoused. They're unhoused because of, the policies that lead to us having inadequate housing for certain populations. And we need to call that out because despite
Mhm.
the backlash against science, the backlash against, experts, people still trust doctors and they still trust public health practitioners. They trust us to, bear witness and to tell the truth. And I think that this is a time where we need to step up and say, those gun policies, those reproductive, health policies that you have are killing people. And here's what we're seeing.
Understood. And do you feel as though when you do that, you're being listened to or that it has an impact?
I think so. I think so. I do a lot of advocacy work around gender and racial equity advocacy, and we've met a lot of our city and state elected officials. And one of the things that they'll often say to us is, "Thank you for coming and telling me about this problem." And I think to myself, well, I live this problem. So it's what I think about, the inequities in medicine. I think about this a lot. Yet they don't. They think about balancing the budget. They think about getting reelected. They think about, and so the space that we can come into as clinicians and as people who are providers and taking care of patients in speaking with a lot of these elected officials who determine the policies, there is a desire to hear from us. And there's a
Okay.
desire to understand, I think,
Okay.
more of what's happening.
Have you seen a change as a result of your advocacy?
Yes, we
Fantastic.
have. We have.
Fantastic.
Yeah, we
All
have.
right. Let's go back to your timeline. So you
Sure.
get into medicine and you realize it's not the medicine that your mom practiced. What happens then?
I start to think about what I want to do to be able to kind of survive in this system. And I think, well, I love global health. I love, my family is from West Africa, and I've
Hmm.
always had this desire to kind of be in community
Hmm.
with folks back home to think about how I can use my, exceptional training, all these years I put into it to benefit back home. And so I joined a Global Health Institute at Mount Sinai. And I was doing work both in domestic policy and in global health. And what I experienced at Mount Sinai is a final kind of thing that really did radicalize me because I experienced the kind of gender and race-based discrimination that was striking and that led to multiple individuals, mostly women, about 13 of us, leaving over the span of 2 years. And the reason why this was very striking is because when a group of us finally went to human resources and said, there's a problem with this institute, we got to figure this out. The response was further gaslighting and further silencing of us. And it made us realize that the kind of pathology that we were seeing in our department and our unit wasn't just affecting us as employees, as staff, as faculty, same kind of refusal to see the problems could ultimately impact patients. And I can tell you a story of how we saw that play out. And so it felt like it was important for us to stand kind of 10 toes down and say, this isn't okay. We have to speak up and we have to do something about it. And when we did, I left my position in that institution and I started my own healthcare improvement company and have been on my own. So I got that independence that my mom taught me. I got that back. And I think that that's what's ultimately made me so happy with my career.
If you can, could you provide details? What did, sounds like there was sexism
Hmm.
and racism, or what does that look like
Yeah.
in real life?
So yeah, so we are still in an active federal and state lawsuit, and so and our case is public, and so you can read about it. What it looked like was the women in the department being paid less, the women in the department being forced to kind of share cubicles while the men had all the offices. It looked like people making comments about other individuals' religion. I was called a mother hen for trying to take care of my team. And so it's these, and I want to say, sometimes when we talk about discrimination and racism and sexism, people expect to hear something like, well, they called me the N-word, or I was assaulted at work. And what we see in a lot of these corporate spaces is it's milder. And I use the term death by a thousand paper cuts, but that's really it, right? You don't know if the thing that was said or done is out of pocket, out of turn. And so you kind of take a moment and you're wondering, and over time, one of the things that I talk about and I teach about now is you want to write things down because when you write things down, you can see the patterns, right? And you can stop kind of gaslighting yourself, if you will, that no, nothing is wrong. This is just medicine. And I want to say the culture of medicine is particularly hard because it's an apprenticeship model. And so as an apprenticeship model, you have to get trained to be better. And part of that training is critiques. No one who's a doctor isn't used to being criticized. The issue is it becomes a point where it can be too much and we can't always tell. And so what we experienced in our situation at our institution, Mount Sinai, was really, really difficult because many of us were like um, kind of refusing to see what was there. And it was only when we saw others breaking down, crying in hallways, others being dismissed, others not being compensated, that we could say, no, something is wrong with that. Something is really, really wrong with that.
Now, compensation is clear, but I'm thinking that someone might say, oh, you're just too sensitive.
Mm-hmm,
Oh, you're probably tired because you're post call.
mm-hmm,
And when you get some rest, you'll feel better. So
mm-hmm,
you're correct that often those insults, often those hurts are very subtle.
mm-hmm,
And it's hard to say that's racism right there.
mm-hmm, mm-hmm,
That's sexism.
mm-hmm.
I'm curious that a group of you were able to come together. And that's very
Mhm,
unusual because usually it's a solitary experience
mhm,
that you
mhm,
keep to yourself,
mhm,
or
mhm,
maybe a best friend, you might tell.
mhm.
How did the coming together happen?
Well, it's so interesting because I think that there was a desire, to your point, to kind of like sublimate the insults and the toxic environment when it related to ourselves. It was harder to do that when we saw it happen to others. So I had a colleague who's in the lawsuit with me say, I was made to feel by our former boss, I was made to feel like I was not intelligent. And one of the techniques would be to outline a project in a certain way, and then you start working on the project as it's been outlined. And then, this boss would come back and say, I never told you to do that. Like I don't know where you came up with that, right? And so it's the equivalent of one week you're told that, the desk is blue, and so you proceed as though the desk is blue, and the next week you're told no one ever said the desk is blue, it's red. And so she was experiencing this and she was starting to doubt her kind of understanding of reality, her ability to take notes and be clear and work. And she said the moment came for her where she knew that he was the problem when he said to her, I taught Stella how to think.
Oh,
Stella wasn't that smart. I taught her how to think. And this colleague of mine said, this woman, I've met her and I have talked to her. She has 3 degrees from Harvard. She is extremely competent. It is very difficult for me to believe that he taught her how to think and that she is stupid without him. And so it was her moment. It was her moment of revelation. And I think
wow.
it then kind of led to conversations where it was like, well, this is happening to me. And, the other person would realize, well, this is happening to me too. And we were able to kind of understand that we weren't isolated. Because part of what happens in toxic and abusive work environments is they keep you isolated and they keep you convinced that it's just you. There is power. If you trust your colleagues, there's power in breaking past those isolated circles and saying, here's what I'm experiencing, and kind of going from there.
So was it sexism or was it racism or does it even matter what it was?
I would say it doesn't matter. I would say there were 8 individuals. There are 8 individuals in our suit, and so each of us had different complaints,
All women?
different things. No, there was one man in there.
Okay.
And so the combination, I think, is why I say, and also age, gender, race, because part of what happened is some of the older folks who'd been in the institute were pushed out and talked about in a very derogatory way about their age, um, because they were older than the young man that they brought in to run the institute. And so in collective, we were kind of looking at all of those different factors that impacted us.
Okay. So how did this end for the eight of you?
All of us have left. All of us left the institute, and I was passionate about the work that I was doing and had really, really great colleagues. And many of those colleagues supported me to leave the institute and to go into another part of our organization. But I just never felt comfortable because I felt like I had a target on my back in
Sure.
some ways.
Sure.
In the roles that I was working in a kind of administrative leadership role. Interestingly, though, I kept my clinical position. So I still see patients out of Mount Sinai in our HIV practice. I love my patients. I love my staff. I can only say good things about my experience as a clinician there, but that wasn't the case for me as a faculty member in a lot of ways. And so, it's interesting to kind of separate those things out. And it
Sure.
gets to this point of sacrifice, right? What we sacrifice when we're in these toxic work environments and we have to get out, we often sacrifice these beautiful patient-doctor relationships that we formed for years. I joined Mount Sinai in 2015.
Mm-hmm.
When this lawsuit is all said and done, they'll probably end up pushing me out of my clinical role. And what's so sad for me is that's 10 years of relationships with people who I have seen through some of the hardest moments of their clinical journeys.
Mm-hmm.
And that's what we lose when we lose good people in medicine, when we drive them out, when we create these environments that are toxic and poor, right? We lose clinicians who trained all their lives to be here for their patients. And patients then get back into the system. They have to find a new doctor and, so on and so forth. And so it's why I feel so passionately about keeping people of color physicians in the healthcare system.
So that brings us to your current project.
Yes,
It seems as though along the way you realized that this wasn't just a singular experience, and that if you had this experience, there may be other practitioners that have had similar experiences. So, what did you do?
absolutely right. One of the things that we did, and one of the things that I always said when we joined the lawsuit is that no one wants to be in a lawsuit. No one trains all these years to go and be in a lawsuit against a multi-billion-dollar corporation. So what I said when I joined the lawsuit is I said, whatever happens, I want our advocacy to live on and to help people. That is
Mm,
so important to me.
mm,
And for me, it isn't just employees, it's also staff. The same administration and HR department that kind of gaslit us and tried to convince us that nothing had happened, even though they found that something had happened, but then the dean came back and was like, make it go away. And so that's what they tried to do. That same administration was responsible for overseeing a situation where a doctor was sexually assaulting patients, Black and brown women, and complaints had been brought up. They looked away. It wasn't until one of the women who
mm.
he assaulted took her clothing that had his ejaculate on it to the police, and it was tested that charges were brought. He lost his license, he was jailed, etc. But there were complaints, there were issues, and so it's the same pattern, right? This kind of desire to not see the abuses, to not see what's there. And that's why it felt important for us to speak up. When we spoke up, over 1,000 individuals signed a letter of support about, yes, there's discrimination in this institution. Yes, we have issues and we want to really be mindful of how we improve as an institution. And there were some changes that were made. I don't know how deep and thorough they are, but it was a moment of acknowledging, I think, among many individuals, not just in Sinai, but across New York and nationally, medicine has a rot problem and we have to address it. And people came out and really spoke up about what they were experiencing as well, which is what led me to the work that I'm doing now.
So, were these doctors or health
Across,
professionals?
yes, across the span, nurses, social workers, doctors, PhD students. A lot of times, fellows and PhD students are in these very kind of subservient positions, and the abuses they face are tremendous. Those individuals came out. Attendings, people who are at the middle or end of their careers, talked about, being targeted by this administration, by the leadership at our institution. When I tell you that the majority of the years after we filed this lawsuit were spent just talking to people, people would come out of the woodworks because they knew that we were public about what we've been through, and they would share with us and they would ask us for advice. And they would say, how do we navigate? What do we do? And oftentimes my advice was, don't do what we did, right? We went into HR and we thought we were being good citizens of our institution by reporting, abusive practices, including IRB violations and all kinds of things that we were concerned about. We thought we were being good citizens, so we went in there. The dean told my former boss when he was brought into HR to get a lawyer, that
Mm.
if he got a lawyer and he went into HR, the conversation would go better. So he came in one step up. So part of my advice now when people are going through what they're going through, I say, don't do what we did and wait so long to get a lawyer. Seek legal counsel early just so you can understand your rights and so that your institution can understand that you're not to be, kind of disregarded and treated poorly, and they can treat you the way that you deserve to be treated, which is as an entity and as a person who just deserves respect. Ultimately, that's what this comes down to. There's a lack of respect, I think, for many of us and how we're treated that ultimately bleeds down to our patients, and we cannot stand for it.
Right. So your conclusion is that this is not an isolated problem, that many professionals, healthcare employees are experiencing something similar to what you experienced in their own institutions.
Yes, very much so. And there's statistics that say that I think it's between 50 to 75% of Black doctors report throughout their career facing some instance of discrimination, whether it's from their peers or leadership, or whether it's from patients. The kind of literature on women experiencing gender-based discrimination in the workplace is up to 40 to 45%, depending on which studies you look at. So it's majority numbers. It's people who are, every other person has a story to tell. And again, we often just push it down and we say that's part of the career, we'll figure it out. And I think insofar as you can still thrive and be successful and okay, do what you need to do. But what is happening, right,
Mhm.
is that people are being slowly smothered, if you will, in these systems that are abusive. And they either retire early or they show up as totally different than how they can show up. And that's why I told you about, seeing my mentors when I was a resident and being impacted by how they were changing because you don't go into medicine to be kind of a small version of yourself and to barely help people. You go into medicine to just pour your love into your practice, into your
Mhm.
patients. And I think what happens over time when you're in these toxic, abusive, and discriminatory work environments is you make yourself small and you feel angry. And that anger and smallness and all those emotions can then be transmitted over to your patient interactions. And that just is not acceptable to me. And so I need us to do better. I need us to do better by each other and by our patients.
How do we do that?
Well, I have thought about this a lot, and I think it's a two-part solution. One of it is policy. So you asked if, some of the advocacy work that I have done has had an impact, and yes, we were able to pass a law in 2021.
Mhm.
The group that I advocate with, Equity Now at Mount Sinai, we passed a law with City Council, and it set up a gender and racial equity advisory board that oversees the state of discrimination among New York City healthcare delivery systems. That group just convened pretty recently. It took a while to convene, so we had to go back after we passed a law and advocate to city council members and say, this is a law, let's bring this group together. All of that work, the group has come together. So that's a policy level. That's changing it at the system level. At the individual level, though, right? Like as we're working to make these systems better, there are individuals who are experiencing these hardships day to day. And so I created the Thriving in the Last Mile workshop. We're going to have our first workshop of this season on September 30th, and it's a 75-minute workshop. And what it's meant to do is it's meant to empower the individual. So you are a medical student, a fellow, a young attending, who identifies as a person of color, and you're in these environments and you are feeling under attack. You are feeling like this place isn't safe. This place doesn't kind of look out for me. I know that I am not just imagining this. There are real toxic traits happening here that's affecting my ability to work. What the workshop does is one, it helps you to understand and identify it because admitting it to ourselves is sometimes the hardest part.
Mhm.
And then it prepares you to be able to kind of withstand and navigate those challenges. And so it asks you to think about what your kind of support system looks like, what your financial support and resources look like. And it really takes you through these things systematically. Then we talk a little bit about advocacy. How do you advocate for yourself? How do you advocate also as a collective? And the goal of this is simple. I don't want people to get through their medical trainings and then just to survive, hanging on by your fingernails. No, I want us to get into these systems and to thrive and to be our full selves so that we can really take care of our patients the way that we know that we want to and we're able to. And so Thriving in the Last Mile, September 30th, and I hope folks will join us. And we do this twice a year. So if you don't catch this session, we'll do it again in a couple of months.
So, thriving in the last mile. Explain
Mhm.
that name.
It's exactly the idea of we're in the last mile now, right? We have gone through all these years of schooling, now we're a medical student. We've gone through all these years of residency, now we're a fellow. Or we've gone through all these years and now we're an attending. We're in the last mile, if you will, of our kind of careers. We've made it. We are doctors. And we now want to be able to thrive and not just survive. And unfortunately, medicine, as I've experienced, as I told you, many other individuals have experienced, you get to these kind of levels where you are in attending, where you've arrived, and instead of feeling like you're in your element, you're getting bombarded and you're getting kind of, hit in so many different directions. It's not by accident that recently, with the federal targeting of diversity, equity, and inclusion, it's Black women that have been driven out of the workforce. Can you imagine? You trained so hard to get to this point, and then you get to this point, and unfortunately, you get fired or something happens. You're not thriving there. You're barely surviving, right? And so what I want and what the name really speaks to is how can we help each other? How can we arm each other with the tools and the kind of network that we need to be able to thrive in our medical careers? Yeah, so we used to do it for people of color, Black and Brown folks, Indigenous folks, and primarily for women. And that was because we felt like we wanted to really kind of curate the audience. Recently, with everything that's happening in this country, we realize that we need to expand and we need to be speaking to people of color physicians across the gender spectrum because all of us are under attack. We know that Black men are among the least represented in our profession. And so when I think about what this workshop and these conversations and this network can do, as much as I'm very much about just pouring into women and our kind of protected feminine energy. This is a time that feels like we have to be looking out for everyone, for all of
Well,
us.
okay.
And so it is open to men and women and however you identify gender wise. And it is for Black, Indigenous, Latino individuals who want to join us.
Okay. So anyone.
Anyone.
Okay.
I will say, if you are a white person, a white presenting person who feels a desire to join this space, you are welcome. It is focused on those who have had a minoritized experience. And so that is what we are kind of catering to, a minoritized by race experience. And that's what we're kind of catering to.
And physicians only.
As of now, it's primarily physicians, but I'll be honest with you, I've gotten a couple of PhD students, I've gotten a couple of terminal degree nursing students. Like I will say, you can probably hear it in the way that I'm talking. I just want to help as many people as we can. So if you're listening and you're thinking this could be helpful for me, you join us. We will make space for you.
All right. And this is a workshop, a one-time workshop.
Yes, it's a one-time workshop, but what we do once you're kind of in our family is we'll send you some materials, which kind of are like preparing materials to help you get into the mindset for the workshop. And then we stay close. So if anything comes up and
Hmm.
you're like, huh, what was that conversation I had with that lady way back in the day about surviving toxic work environments? You will see us. We'll have newsletters that go out and you can reach out. You can say, hey, Stella, or I have a group of individuals that I work with who are similarly kind of attuned and able to really work through these tough situations. If I can't help you, I can connect you with someone who can. So it's not just a workshop, it's a resource. And part of why we're trying to do this is to get people pulled in and connected so that you're not, as you said, you're not on your own. It
Hmm.
is through our collective action that we're able to protect ourselves. And so we feel very strongly about really building deeply into that collective action.
Have you heard any concerns that persons might feel as though they get stigmatized if it's found out that they're participating in this type of workshop?
I haven't, but I can kind of extend my mind to think that might be the case. I think like it's a little bit of a tool of white supremacy to try to convince us that when we kind of combine our smarts and our resources to really help each other, that somehow we're doing something wrong. And so like my natural response to that is, we're often in these spaces that are just by default very white, very male. No one ever questions that, right? If you take specific action to be in a space that is more diverse, that is, separated by gender, whatever it is, there is nothing wrong with that in a world, in this kind of environment that we're in, where again, the default is, as we know it, to be white male. And so I hope it doesn't sound at all like defensive, or I just want people to feel confident in declaring the spaces that they want to be in to get what you need to get for yourself. Because I think this is a time where we can't be shy about taking care of each other and taking care of ourselves.
Hmm. 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 Is there a cost for the workshop?
Nope, nope. I really believe, especially for trainees, people who are still coming up, we just, we don't have funds. And so I really want to make sure that people are able to access this. And we work really hard to get funding for it. That's one of the kind of my open asks if, folks are listening and they say, "Oh, I really want to help support this work." We are open to that partnership for funding for resources, but as long as I can be a part of this, I work very hard to keep it accessible and affordable to everyone who wants to join.
And it's virtual.
It's virtual, yes.
And what day is that?
It's Tuesday, September 30th at 6 p.m. Eastern Time.
September 30th. So coming up
Yes,
soon.
it's coming up next week.
How would someone find a link to this workshop?
Yeah, so you just go on thriving in the last mile. So that whole phrase, thrivinginthelastmile.com. And on that website, you can learn more about what the workshop is, and then you can register there.
Any parting words for us?
I just want to tell us that we're wonderful and and I'm speaking specifically to Black people here. We are going through a time, and Black women in particular, we're going through a time where we're under attack, but we have to remember how sacred we are and how blessed and just grounded we are and hold on to that. Because I think we're in a time where it can feel like, you don't know your front from your back, your right from your left. But we are wonderful, we are divine, we are going to be okay. And I want to leave people with that sense.